Good afternoon if you're on the East Coast or I guess anywhere east of us. This is Brandon Garrett, the National Minority Equality Forum. Welcome you to today's Friday webinar on data and data equity. If you know anything about NMQF, which you probably do since you're in this webinar, is that there are two big things that we're founded on: equity and data. And so with that, I'm gonna let somebody that's probably been working with NMQF a little longer than I have and more intimately than I have, Courtney Lang, who's always been sort of a great supporter and great person to work with NMQF. So I'm gonna turn it over to Courtney and she's gonna lead today's webinar. Oh, but before she does, I do remember 2 weeks, our annual summit on health disparities, and I'll put a link for that in the chat. All right, Courtney, sorry.
Thank you so much, Brandon. Good morning and good afternoon to the audience and to our esteemed panel. We are concluding the National Women's History Month, and tomorrow we are starting April, National Minority Health Month. And we are delighted that you have joined us today. My name is Courtney Lang. I run a health equity and social change public affairs firm based out of Washington, D.C., and I am delighted to serve as moderator for the National Minority Equality Forum webinar today. I want to take a moment and just extend a thank you to Brandon Garrett and Dr. Gary Puckrin for their leadership and this opportunity. Our webinar today will focus on data equity, and specifically we'll review the issue brief just released this past Tuesday, Standardizing Data to Advance the Health Equity Movement, a multi-sectoral strategy that was released, again, this past Tuesday, March 28th, and a link for the brief will be placed in the chat as well. I am joined by a fantastic panel. First, Dr. Gary Puckrin, founder and CEO of the National Minority Equality Forum. He will bring greetings and ground us in the historic commitment to data and data equity that NMQF has championed. He will be followed by Gretchen Wortman, lead author of the issue brief and vice president for policy and program at NMQF, and the director of the Institute for Equity and Health Policy and Practice, and director of the NMQF National Alliance on Brain Health and Awareness. Followed by Denise Schofield as executive director, data equity at the Blue Cross Blue Shield Association, a national federation of 35 independent community-based and locally operated Blue Cross and Blue Shield companies. Denise is responsible for developing data leadership priorities for BCBSA and the partner ecosystem. And Raj Banot is a senior project manager with the American Heart Association's Health Business Solutions, formerly called Emergency Cardiovascular Care. He recently led the AHA's ERG, representing Asian American, Pacific Islander, Native Hawaiian, and South Asian communities. Their perspectives as a panel will amplify inclusion, augmentation, and visibility of data within the broader context of the health equity movement. So without further ado, Gary, I'm going to turn it over to you to bring greetings to the audience.
Thank you so much, Courtney, and thank you for all of the great work that you've been doing. I also want to take a moment to thank the Blue Cross and Blue Shield Association for the collaboration on this project. Data is at the heart of NMQF. When we were founded back in 1998, it was founded around collecting health data, which we've been doing for 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives a year. We use that data in everything that we do. We publish, we in community, anything that NMQF is doing is about data. And so we're excited about the idea of getting data standards. We realize that we need to make real strides and improvement in the collection of health data, both in the standardization of race, ethnicity, and SOGI data. But we also need to make sure that we create a rich data environment because that's where health equity is going to get resolved. And we just, again, want to take a tip of the hat to Blue Cross and Blue Shield for really taking leadership in this area and collaborating. I think one of the things that I would really call out in the recommendations that are being made is the non-voluntary recommendation. That's a really big deal. And just really thank Blue Cross and Blue Shield for signing off and being a part of that. So we look forward to this collaboration. You've got a fabulous panel, and I'm going to get out of their way, and I'm going to turn it back to Courtney Light. So thank you so much.
Thank you, Gary, for those greetings. And I am delighted actually now to turn it over to Gretchen Wortman to give us a little bit of an overview on what is the purpose of the issue brief and what NMQF hopes to achieve from this collaboration. So Gretchen, thank you so much for your contributions on the writing of the issue brief. You're muted. Mute. Thank you.
But technologically challenged, I guess. So my name is Gretchen Wortman, as Courtney noted, and I'd like to add to Dr. Puckrin's comments that the partnership with Blue Cross Blue Shield Association, that is the backdrop, excuse me, of our webinar today, enables NMQF to advance our foundational objective, which is to assure that data are available to enable best possible care and outcomes for all population cohorts. This includes, but is not limited, to those of us who historically have been marginalized by the health services research delivery and financing system. Lack of data representing the experience of marginalized populations, as most of you know, is a long-standing and interestingly recalcitrant issue. Which data are collected, how and where they are collected, and most importantly, how the data are structurally integrated into America's system of creating and sustaining health is an ongoing challenge. And that's why NMQF is here. And that's why the issue brief exists to summarize conversations that we've held with key stakeholder organizations, patient advocacy groups, and others to make sure we are informed, that our activity is informed by their perspectives, and I will say their concerns, because these tend to represent populations who have, I will say without thought, but sometimes, unfortunately, intentionally been excluded from the conversation. And lack of data to reflect your existence and to enable your inclusion, our inclusion, in the creation of new knowledge that informs new therapies and improves care and outcomes for all population cohorts is why we are here. And we are here at, I think, what may be a watershed moment in American health services history, simply by virtue of a number of disturbing, very public events that highlighted biases against certain population cohorts and the degree to which our systems of caring for Americans, whether healthcare or otherwise, are failing to meet the challenge. We are here to help assure that the health services research delivery and financing system is prepared to meet the moment and move forward into a future that creates, that reimagines and then creates a research delivery and financing system that embraces all of us. And so I will turn this back to you, Courtney.
Thank you, Gretchen, for the overview and for the details about what really galvanized the stakeholders to come together to inform the writing. And I thought that was such a great point that you made about the convenings and really taking the input in from so many different advocates in the health equity movement. So thank you so much. With that, Denise, you have also been central to the data equity movement and the contributions from Blue Cross Blue Shield Association. So delighted to get your perspective on where you see the opportunity is to champion data equity moving forward.
Yeah, and thank you, Courtney, for the introduction. Thank you to Dr. Puckrin and to Gretchen for their partnership and collaboration on this very important issue. Building a little bit off of what Gretchen was just mentioning about some of the pivotal moments that have happened within the last few years, thinking back to 2020 and the unfolding of the pandemic, thinking about the social and civil unrest that soon thereafter followed, a lot of the health disparities and equities that have historically been part of our communities in the US were laid bare in spectacular fashion. And I think that galvanization around the work that each Blue Cross Blue Shield company does individually in their local communities really brought our board of directors together in 2020 to, for the first time, develop a national health equity strategy. And one of the key pillars of that strategy is data leadership, recognizing very early on that the way to solve some of these issues, the first critical step is the data. And the data need to be accurate, they need to be complete, they need to be representative of the diversity within our communities, and they need to be updated on an ongoing periodicity. And what we found in working with our local plans is that, as Gretchen was saying, the source of the data, the provenance of the data was oftentimes varied and difficult to analyze in a way that was respectful of the individuals or the subpopulations that we were seeking to learn more about. So with that and the development of that health equity strategy in 2020, the goal is really to change the trajectory of those health disparities and health inequities, starting with data, and specifically with data equity, and making sure that how data are collected, how they're interpreted, how they're analyzed and used in models is reflective of the intent and ethical use to meaningfully impact those disparities and inequities. What I mean by standardization is if we look across the standards available today, there's not interoperability. There's not one standard that's used by both government agencies and private sector. There is very little disaggregation today of race and ethnicity categories. So what we have found in our own research is that when individuals see the traditional OMB 5 and 2 responses, a lot of times they don't see themselves, they don't see their identity in the responses available to them. So there has to be a disaggregation of those categories in order to enable us to understand for each individual what is the best approach to whatever intervention it is that they may need. The other important component is sexual orientation and gender identity. We know that the work that we need to do to close health disparities and health inequities includes those characteristics as well. And so when we talk about health equity data, as the Blues, we talk about it as race, ethnicity, language, sexual orientation, and gender identity, as well as social drivers of health. And so all kinds of different issues there related to food insecurities, housing instabilities, all things that Blue Cross Blue Shield plans locally have championed and addressed in their individual markets. But now as a system, recognizing the scale and the fact that we insure 1 in 3 Americans and have membership in every single zip code across the US, the opportunity to address health inequities and disparities isn't an option, it's an obligation. And it's something that we view as an imperative to work cross-stakeholder to really come up with an answer to how we do this in a way that's interoperable, in a way that's reflective of the diversity of our nation, and in a way that promotes ethical use of the information that is then collected. And that's, if you look at the issue brief, a lot of those components are part of the recommendations that we developed in partnership with the NMQF. So I'll pause there, Courtney, and see if there's anything else you'd like me to add at this point.
That was wonderful. I was hoping, Denise, maybe you could just add why data equity is so important to the payer community. I think that would be really helpful to the audience to understand Blue Cross Blue Shield Association's commitment.
Yeah, it is incredibly important because without data equity, you cannot design interventions to help the populations that you insure. Without data equity, we're unable to address meaningfully and reduce the health disparities and inequities that we're seeing in the system that have historically been part of our nation, regrettably. Without data equity, it's impossible to address those things in a meaningful way. So that is why we are championing the data leadership and the development of data equity. So it goes beyond just collection. It goes to the type of information collected. It goes to the use of that information, all the way down to the data scientists who are analyzing that information, making sure that we are offering opportunities for individuals who have lived experiences to pursue those types of fields, because that's important when it comes to research, and it's important when it comes to data equity. So.
Super helpful. Thank you so much, Denise. And I wanted to make sure that the audience was empowered to ask questions for the panel. Please feel free to use the Q&A component at the bottom of the screen and submit your questions in the Q&A box, and we'll make sure to field those questions to the panel directly. So thank you, Denise, and we will circle back. I know there's a number of questions that have come in, but I want to make sure that we also have an opportunity to hear from Raj Banot. And Raj, you have been on an amazing journey with the American Heart Association's broad and very bold commitment to addressing health equity and systemic racism. And I was hoping you could share with the audience more about that commitment, how data equity fields into that, and perhaps some personal reflections that you have on the importance of this space. So thank you so much.
Absolutely. Thank you for having me here. So first, I want to start off by just a little disclaimer. I do not represent the policy or advocacy goals of the American Heart Association. And I think Courtney, at the outset, let you all know that, for the past 3 or 4 years, I have been leading our employee resource group. So I work specifically in resuscitation, which has some impacts to different communities. But I want to tell you a bit about what the journey was of the American Heart Association and what it meant for employees. So as Denise mentioned, 2020 was tough for many people. There was social unrest, the pandemic was starting, and we all found ourselves searching for answers. So I think the American Heart Association took that opportunity. Our CEO, Nancy Brown, and the board looked at the impacts of systemic racism on health equity. So I'm going to give you just a brief overview, and I will send some links in the chat shortly after this overview. And then, as Courtney mentioned, I'll give you a kind of a personal anecdote of why this is so important to me. So just let me know if you see screen, give me a head nod. You okay there? You see screen? Yes,
Yeah.
okay. All right. So 2020. Sorry, give me a second here. A little technical difficulties, which often happen, right? Okay, we are back. We're good. Can you give me a head nod there, Courtney?
Yes, we're great.
Perfect. Okay, thank you so much. So in 2020, our CEO, our senior leadership, and the board got together, and they came up with 10 commitments that, as an organization, we committed to a 2024 goal, which were, one, to educate, second, to impact the issues of systemic racism in the healthcare system, and then do some soul searching. So again, we've made 10 commitments in 2020 for our 2024 goal. So that goal is coming up soon. I'll give you just a quick overview of what we did. Okay, so a big part of that 10 commitments was committing $200 million as investments to both community impact initiatives and research to look at systemic racism, including some education that would be available for clinicians. So that includes 100 million in research grants and funds that looks at issues such as hypertension in various communities across the country. I'm going to, we can speak about this for hours, but I'm going to give you just a quick overview so we have some time for questions. Investing in communities and community-led initiatives. So that's another huge chunk of where some of our $200 million is going. And this is all going to be doled out by 2024. So the beauty about this is that the Heart Association really put their dollars where their mouth was. So our third commitment was just improving access to quality healthcare for under-resourced populations. So I'm going to get into a little bit shortly about what we've done with Health and Human Services, but we have $121 million from them to address hypertension in Latinx and African-American communities. As we know, issues like tobacco and sugary drinks impact communities of color disproportionately. So, part of this is just a broad overview of what we've done. What are all the impacts that look at different communities across the country.
Thanks,
Okay.
Brad. Okay.
Yeah, you okay?
Yep, we're good.
Okay. Another part of this is looking at the data. So I want to just run through this and I'll tell you what some of this impact is for me. So looking at the existing data we have, as you know, we fund a ton of research every year, something to the tune of about $200 million in research grants. And that gives us access to a great set of data and studies and clinicians and to look at specific communities. So our Target BP program is one of those amazing things that we've done with the American Medical Association. We do offer now hypertension access, monitoring access to 30 million patients across the country. So this is not work that we've just done. Are we not getting slides advancing?
That is correct. They're not
Okay.
advancing. So I was hoping that what maybe we could do is to share the information as
We
a
can do
follow-up
that. Yeah.
so that we can PDF it and have that sent out by National Minority Quality Forum so that the audience has the ability to, but the information is being heard and we do have a number of questions in the chat.
Okay. That's great. I apologize for that. So I'm happy to send this out as a PDF and include the links after this panel. Our seventh commitment was, this is not work that the American Heart Association does alone. We have a CEO roundtable that's comprised of over 50 CEOs, many of them from Fortune 500 companies. And so we are able to impact, over 100 million people through various media channels through that partnership with the CEO Diversity Council. We have created a digital learning platform for clinicians and health professionals and we're providing training in the form of e-learning courses on the issues of the impact of structural racism and how we can look at some ideas of improving health equity in the delivery of healthcare. Okay, so it's not only patients, it's also volunteers, it's clinicians that are involved in research, it's the makeup of different boards. So those are all issues that we have looked at and are improving both externally and internally. One of the last things I'd say, which I think is the coolest, one of the coolest things that we did is we made mandatory training on systemic racism for all employees across the organization. We are able to share that with other institutions. Part of that is also addressing what our workforce, our board, our volunteer groups, what they look like across the country, including both at National Center and the affiliates that we have across the country. Okay, do you have me on camera, just so I don't have any other glitches?
You are.
Okay,
You can actually pull down that title slide since the slides weren't advancing.
yeah, thank you.
Sure.
They were advancing on my screen, so I apologize for that.
No problem.
So I'm going to give you a bit of a personal anecdote. You know, as I think that Courtney mentioned, I have been president for our employee resource group that represents Asian American, Native Hawaiian, Pacific Islander, and South Asian employees. So that group essentially represents, you know, 50% of the world's population. I am, prior to moving to Dallas in 2008, I moved here from Canada, so proud Canadian, but now also a dual citizen. When we moved here in 2008, the healthcare system was foreign to me. So for the first time, I had to select an insurer through work, either myself or through my wife's employment. So that process was new, and I think I'm somebody who's pretty familiar with the healthcare system, can navigate it pretty easily, and have access to a large network where I can get advice just by making a phone call. So one of the interesting things that I noticed, you know, as a 30-year-old, was that for the first time in my life, I didn't have a box to check. So the only box to check was Asian when I was identifying my race. And I can tell you that my genetics, the food that I eat, and other, you know, cultural issues with my parents originally being from India are not the same as somebody who might be from Japan or have Japanese heritage. So you know, I started talking about this internally, even prior to the 10 commitments that we made. I was invited to lead our ERG. And then what I noticed is in some of the formative documents of the ERG, you know, they had looked at the issue of data disaggregation about de-lumping that broad category of Asian. So one of the things that I will tell you is when I send out the deck, you'll notice that we talk about systemic racism, and as the Heart Association, systemic racism and health equity, but we don't mention data in there anywhere. We don't talk about data. So I've been making the push with some other employee resource groups to have a specific commitment made about data equity, data trust, all of the issues that go along with that. And so I'm here, you know, 16 years later, living in the States. I think there might have been one occasion recently where I saw a healthcare provider, and that health record system did give me the option to check South Asian. So I know this work has been going on state by state. What I'd like the commitment that I'd like the AHA to make is to plant their flag and commit to data equity, in addition to health equity and the barriers that we have with systemic racism. And so this is a great platform for me to talk to you about what we are doing and what we're not doing. And so that commitment to data equity is something that leadership is hearing about. They get some emails from me every once in a while to remind them that how important this is. You know, my sense is that we can't have health equity without data equity. So just echoing those comments that Denise and Gretchen made earlier. So I'm happy to be on this journey with you and continue our discussions and perhaps push an organization like the American Heart Association to do more about data equity. So I'll pause there. Courtney,
Yeah.
if there's anything else?
That was a great overview. Again, to the audience, we apologize for the technical difficulty. The slides will be available via Constant Contact. They're going to be disseminated by National Minority Quality Forum to share. But Raj, I really appreciate the personal story that you just provided to all of us and having the right box to check. And I think that's such an important aspect of the conversation and why we're here today. And I was going to ask both Gretchen and Denise why checking the right box is so important to inform the recommendations that were placed in the issue brief. why checking the right box is so important to individuals representing race, ethnicity, language, sexual orientation, and gender identification. So Gretchen, we'll start with you.
Thank you, I think, Courtney. I think I would reframe the question as it relates to collection of data, making sure you have the right box to check, which is what I heard from Raj. But I would say through the NMQF lens, one of our concerns is that the issue of equity is at risk of becoming a box checking exercise, and that equity somehow will be one of the criteria or standards for evaluating the contribution of a program. Our challenge, and very specifically being implemented through the Institute for Equity in Health Policy and Practice, is to facilitate or participate in conversations that enable those with agency in either the political, economic, or regulatory sphere to redesign our system so that equity is central in everything we do, whether there's a box that needs to be checked or not. And to us, that is the, I think for everyone, that's the clearly aspirational challenge, but it's doable. It's doable, but it is only doable if we undertake this journey through that lens, that somehow equity is not an option that a provider or a system or a policy offers. And so I would say that the NMQF Blue Cross Blue Shield Association partnership, while we're looking forward in terms of where we want the system to go, also presents to our stakeholders a very immediate opportunity to inform this process, and that is the review and revision of OMB Statistical Directive No. 15, which for the federal government defines standards for maintaining, collecting, and presenting federal data initially on race and ethnicity, and that's where their authorization lies. It was first promulgated in 1977, Directive No. 15. It was revised once in 1997, and will be revised again in 2024. And each time there has been an opportunity to expand, I think, within OMB, and then therefore communicating it to the federal government and all of the federal government's partners, expand the understanding of not only what the standards should be, but why this country needs to collect them and use them in a way that not only enables populations to be represented in our system, but I'm going to say takes it forward to make sure that we are reflected in the work that is done, whether it's in research, in approvals through FDA, in value assessment processes that occur throughout our country. So I think I'm probably answering more and less than you asked me.
No, that was fantastic.
But I will say that given the given precedent here for a directive that was initially promulgated in 1977, the chances of having another opportunity to influence that directive after 2024 at the earliest would present in 1944. And possibly later. So I encourage everyone to seek and work with us to seek the immediate opportunities to engage with these issues in the legislative and regulatory universe, as well as to work, as Raj is doing, within his environment and your own environments to broaden an understanding of the essential nature of these conversations to equity in our country.
Thank you, Gretchen. And Denise, I was going to ask if you could expand on why standards are so critical, kind of piggybacking off of what Gretchen shared. And there was also a question in the chat that also speaks to this, and it's the ability to select multiple races and ethnicity. How will that impact health data by adding that ability? And so if you could offer just some additional perspective on how that's helpful. You spoke about the interventions earlier.
Right. So maybe I'll start there, Courtney, with that last question around the changing of how we collect information. And it's definitely one of the things that we need to consider as we think about all the information we have historically, and then how do we trend or create longitudinal research going forward. That mapping exercise is one of the biggest considerations I think we have to think through as we look at disaggregating the race and ethnicity categories, and as we look at adding in the ability for those to self-identify. And I'll just share one finding that we had from research that we did last year. It was a small qualitative study to understand how individuals perceived being asked that question around race and ethnicity. We were really trying to get underneath what is it that someone needs to have present to make them feel comfortable providing that information. And interestingly, and not surprisingly, the decision to share that kind of information is multifaceted. It's not simply checking a box. It's, do I see my identity in the responses provided? What is my experience with having shared this information before? Have I been treated differently as a result of sharing that type of information, whether it's race, ethnicity, sexual orientation, or gender identity? And it's thinking through, how will this information be used, and how can I be sure that it's used for the purpose that you stated for? So it's multifaceted decision when someone's thinking about providing that type of information. In the latter half of this year, we'll be doing a much broader quantitative study to kind of verify the directional findings that we received. But I think it's very important to understand from an individual's perspective, how do they make that decision to share that information? The other thing I'll share is when we look at it from a clinical perspective, and I am not a clinician, but I work with our Office of Clinical Affairs, we do see differences in subpopulations that are masked when you use the OMB5 and 2. And I can share personally as someone of Hispanic descent, but with parents who immigrated from Mexico, my issues are different than someone who identifies as Hispanic. It might be from Puerto Rico or a different part of the world. So it's important to have that type of information so that interventions can be tailored to the individuals who are seeking treatment. I think it's also important in collaborating with providers and health systems to have that type of information so there's a continuum of care for individuals that's appropriate to what their particular issues may be. I'll pause there and see if I answered all the questions you asked, Courtney.
No, I think you absolutely did. And so just to clarify, maybe for the audience, right? So while the experience might have been checking the box, it's the identification, and the opportunity to be seen and to be included in a much broader system of care. And that's why data equity is really integral to the broader health equity movement. One of the questions for the panel that did come up was collaborations with federal partners on data interoperability. And this is for all of you. And Raj, you alluded to the fact that you're not in the policy space, but you do a lot of work with pediatric patients, preparing healthcare providers, recognizing the interventions that really work. And so there's a clinical aspect there to the insights that you're providing for cardiovascular care. So interoperability in data is very important to you. I was wondering, perhaps you could offer a response to the audience on that.
I'm not sure I have that answer from the perspective of the American Heart Association, particularly clinicians. We are looking at what different groups need and who those different groups might be. But we know that even something as simple as educating somebody on CPR is handled differently amongst different communities. And what I would say is that we can't have health equity. This is a chicken and the egg conversation, right? So we started from a place of looking at health equity, and then maybe the data comes later. And I think we're also trying to identify whether it's, do they happen in parallel? Does one come after the other? I just don't think we're there yet in terms of our discussions at the Heart Association to talk about this as in an informed way. So I think, we're starting to plan for post 2024. We are going into our second century of the American Heart Association, and we're starting to look at some of those issues now.
Thank you. Data with interoperability with federal partners. Gretchen, I know National Minority Equality Forum has been at the table for a long time. So perhaps you want to share some of the best practice work that you all have been engaged in this space.
Okay, so once again, I'm going to answer a different question than the one you just asked, which is, yes, interoperability is essential. Okay, and I want to, I guess, remind everyone that this issue brief is signaling the initiation of a national conversation regarding all of the issues that attend data equity in this country. And so we do not yet have the answers. An issue brief doesn't present answers. It presents essentially an outline of an environmental assessment in short order, and then outlines a pathway forward, the beginnings of a pathway forward to creating equity. And what we, and Denise can add to this, what NMQF is looking forward to is continuing to work with Blue Cross Blue Shield and others on interacting, defining all of the challenges, one of which you've raised, Courtney, which is the interoperability issue, but also then having a, I would say, coordinated partnership to addressing and redressing system weaknesses through our different lenses, through the different pathways to which we have access. So I don't have answers, specific answers to your question. I will reinforce the reason that you asked the question and that Raj spoke to it, because absent that, I mean, the data that we do identify and standardize will be, its impact will be neutralized or skewed in some way, depending upon whether all have access to it in the same way.
Thank you, Gretchen. Thank you. Denise, the same question. It was a question that was placed by the audience in the chat. Collaboration with federal partners on data interoperability and the importance of that in this broader effort to advance data equity standards.
Yeah, it is absolutely critical to have interoperability, and Blue Cross Blue Shield companies and the Blue Cross Blue Shield Association have long championed the FHIR standards to create interoperability around data. The issue we have with the collection piece is we don't have universal adoption of a standardized set of categories. The good news is, if you look across what's available through CDC, what's available through OMB, OMH, et cetera, the categories are there. The question now is, how do we standardize those to make them interoperable via the FHIR standards? And BCBSA has been involved in those discussions at the table to ensure that we have that type of data interoperability. The other piece I'll mention is the work that we're doing, Blue Cross Blue Shield Association and plans on the Gravity Project, which some of you on the call may be familiar with, but it's to standardize the collection of the social drivers of health. Again, thinking broadly about health equity, it's not just race and ethnicity, it's the sexual orientation, gender identity, social drivers of health that need to be addressed in order to create equity and equitable access to care for historically underrepresented populations. But it is absolutely important that we have the interoperability, and that is part of the work that we're doing in providing feedback in this comment period to OMB on SPD 15, the Statistical Policy Directive No. 15 that Gretchen mentioned earlier.
Thank you, Denise. And what is the date the due date for the public comment period so that the audience can make sure that they are clear when they need to submit comments. A link was placed into the chat for the audience.
Yeah, my understanding is the due date is April 12th, so it's very soon. And then from that point, the interagency will be doing its work to gather up all of the comments and do additional work. So we're waiting to see post 4/12, the next opportunity to engage with the findings from the initial comment period.
So there are a number of individuals that are on the line who are health equity advocates and champions. So if you're expanding the understanding of why data equity is so integral to the health equity movement, what can the individual do to help support the visibility and prioritization of data equity as an imperative for the individuals that are on this line? Is there a to-do that the participants can really galvanize to help to contribute to advancing the work that has been so beautifully highlighted in the issue brief in the form of recommendations? Is there something that individuals can do, and how can they contribute their voice to the broader process?
Yeah. So, and I'll defer to Gretchen on this. Maybe Gretchen, I just saw you come off mute. If you want to go first, that's fine. So I think to your point, Courtney, the comment period is one way to provide information back to the government as they're considering how they're going to update SPD 15. I think from an individual perspective, depending on where you're coming from, working within your community, working within your health system, wherever your background might be, to raise these questions often, as Raj was saying earlier, raise them often, raise them loudly. This is the opportunity. 43 plus years since this directive was put into place, this is the opportunity to really have our voices heard through whatever organizations you're part of, through individual comments, through working within your local communities. That's what I would say as an individual. That's what I would do if I wasn't working for Blue Cross Blue Shield Association. I'm very passionate about it. So make your voices heard. Now is the time. Now is the time.
Thank you so much. Gretchen, yes, please.
I think I would add to that, that in addition to seeking opportunities within your immediate environment to influence a conversation, I'm going to reference Daniel Dawes and his book on the political determinants of the political determinants of health. And I would say begin to incorporate these issues into your thinking about how and for whom you cast your vote. Because these kinds of decisions often are linked to state general assemblies, to representatives, to the House, to Congress, House of Representatives and the Senate. And then those entities or individuals who are elected inform who's placed in different executive branches to promulgate regulations or create sub-regulatory processes that inform how these values pull through. So I would add that sort of citizenship, good citizenship component as well.
Thank you, Gretchen. And Raj, did you have some thoughts on?
Yeah, I wanted to echo something that Denise said. So, for us, the issue of data equity, systemic racism has been heard loud and clear across our organization. The next step for us is to talk about data equity, and that for us, because it wasn't happening at the speed that we wanted it to happen. This has been an employee-driven, an ERG-driven conversation. So don't be afraid to have those conversations, because people just may not know that it's an issue and how it affects you personally. That's how I've been having these conversations. And I think, Courtney, as it resonated with you, the story of me not having a box to check, and I know that is not the end of the conversation, but it's the starting point. It's me opening the door to have those conversations with other folks so we can get a commitment, we can get it on the policy agenda of the American Heart Association. We at a minimum, what I feel we can do is through some of that $200 million that goes out through the door for research grants and community impact issues, we should make it mandatory that that data is collected through those initiatives. I think that's an easy win for us. It might be difficult on the receiving side, but it we've got to put our foot down somewhere.
Thank you, Raj, for that and for your passion, really, to share the intimate experience that you have had in the space to really be able to influence the dialogue within the association and more broadly with national audiences. As we near our closing time, I want to circle back to the issue brief and specifically the recommendations that were set forth in the issue brief, because they're so important for the audience to understand. A link to the issue brief was placed into the chat. So we want to make sure that everyone is well socialized with the issue brief. But I want to focus, just if we could quickly just identify one recommendation that you really want to highlight for the audience as a takeaway. There were several that were published in the brief, but if there was one that you could highlight that would offer an opportunity for individuals listening to better understand why this is so critical for the advocacy movement. So Gretchen, I might start with you, recommendations, because you really framed the entire conversation and helped to identify so clearly the recommendations that we need to take away as beginning the conversation, as you so eloquently put, and not ending the conversation there. Off mute, yeah, thank you.
Okay. The I would ask everyone to download a copy of the issue brief and read it. It's not, it's, I think, easily scannable. It is not an onerous document, you know. There are only 4 recommendations in the document, and so I'm going to have difficulty selecting one over the other 3, but I would say that one of the recommendations is to encourage OMB to work to expand the authority vested in Directive number 15, to include the SOGI data. It is at this point explicitly sort of limited to racial and ethnic data. Bringing all populations through the intersectional equity lens into the conversation requires that OMB's authority be expanded to include all populations. I would encourage everyone to submit comments to OMB, not only in support of what they're doing with race, ethnicity, and language data, but also with the with SOGI data. And I guess to encourage you all to not readily accept what I hear often, which is that social determinants of health or SOGI issues, or what do they call it? Lived experience metrics are not quantifiable because it's too hard. It's no harder than quantifying the physician experience or the hospital experience, which they've been constantly, they meaning the establishment, improving, refining for at least the 50 years that I've been working. Do not accept from the system that notion that somehow bringing us into the quantified metrics of the conversation is too hard to do right now. So that I'll end with that.
Thank you so much, Gretchen. Denise, do you have a 30-second response to recommendations, key takeaway?
Yeah, I would agree with Gretchen with the 4 recommendations are all equally important in terms of what we're trying to advance with data equity. I think the one recommendation that stands out a bit from how this was done in the past is the non-voluntary nature of the recommendations that come out of SPD 15. So I think that is important because that gives us then the foundation for standardization, the foundation for universal adoption and interoperability of the information that we get. And then we have to quickly think through the use of that data, because that's immediately where the next, kind of set of challenges come. But we have to get off the ground with the foundation. So I think this non-voluntary recommendation is really key to what the issue brief is outlining.
Thank you. And Raj, final thought?
I feel like Gretchen or Denise steal my thunder every time. But what I would say is this is such a pivotal moment in our history. We've had a lot of very difficult conversations as a country, as communities over the last couple of years. And if we don't do it now, when are we going to do it? So I love the fact these recommendations are non-mandatory, and have those difficult conversations, make people uncomfortable. And I think as we're, my guess is the attendees here, we are speaking to the choir. So have those conversations outside of your immediate circles, make people uncomfortable and make them understand why this is so important.
With that, I want to extend gratitude to this incredible dialogue, for this courageous conversation, and for advancing data equity as integral to the health equity movement. Gretchen Wortman, Raj Banot, Denise Schofield, thank you so much. And of course, to Dr. Gary Puckrin and Brandon Garrett, and the entire team at National Minority Quality Forum who hosted us today. We encourage you to be intentional with your advocacy, to understand the importance about intervening and being represented. The data standards that have been set forth in the issue brief reference are critical to all of our collective success in making sure that we are all represented. Thank you for the multi-sectoral strategies that have been reviewed today, and we look forward to continuing and sustaining the dialogue. Thank you all for joining us.
Thank you.
Thank you.
Thank you, Courtney.
Thank you.
Thanks, everyone.